Mas você fica à vontade, Vitor, o dia que você preferir.
Bom, vou começar. So, can you all see my screen? Is it working fine?
Yes.
Okay, that's great. So, good afternoon, everyone. Such an honor to be here and to present a little of my work in my seminar. I'd like to thank Professor Andrea for the invitation. My name is Vitor Mori. Currently, I'm a postdoc at the University of Vermont in the United States. I'm a physicist with a master's and PhD in biomedical engineering by the University of São Paulo. And I'm also a fellow of the Damon Runyon Cancer Research Foundation. I'm also a member of the Observatório COVID-19, which is like a kind of a consortium of scientists to debate the pandemic. And I've been also working a lot in science communication around the pandemic, especially around the airborne nature of COVID transmission and the use of better masks. But today, it's a big honor to present a lot of my own research project in cancer. And it's interesting because I think this might be one of the first times I had the opportunity to present some of my work and not talking about COVID in like almost 2 years. So yeah, I'm glad to be here and such an honor to present to all you. I'd like to thank all the attendees to be here. And my project is intratumoral administration of cisplatin in lung tumors. So I'm going to summarize my presentation. So at first, I'm going to contextualize the problem and how critical it is to find better treatments for lung cancer. And then I'm going to give some background of everything that we have done here in Vermont in the area of intratumoral chemotherapy, pretty much intratumoral injections of cisplatin in lung tumors through a ultrasound probe that travels inside the airways. After that, I'm going to talk a little about some questions that arose from our work, some open questions that we have and that we want to answer. And lastly, I'm going to talk a little about short and medium and long-term steps that we are planning for this project. So here we have a picture of the causes of death in the world in 2017. And I'd like to stress that this is a pre-pandemic scenario. We know that how brutal the COVID pandemic has been and how it also affected the statistics of the main causes of death in the world. So we see that cancer is the second most important cause of death in the world. And roughly 1 out of 6 deaths in the world are due to cancer. If we specifically look at numbers of cancer, there is a predominance of tracheal, bronchus, and lung cancer, like respiratory system cancers in general. And the difference is so big that respiratory cancer has more deaths than the second and the third places together. So if we go deeper for lung cancer, we can say that it's responsible for roughly 1 out of every 4 deaths in the world, which means that out of every 100 deaths in the world, 4 are due to lung cancer, which is a lot of things. And also, if we break lung cancer into 2 most important types, which are small cell lung cancer and non-small cell lung cancer, we have that 85% of lung cancers are non-small cell lung cancer that can be further divided into 3 groups: adenocarcinoma, squamous cells, lung cancer, and large cells lung cancer. So cisplatin is broadly used as a chemotherapy drug through the systemic route, and this is considered the first line of treatment for non-small cell lung cancer. However, this is a very toxic a drug with a lot of side effects, such as ototoxicity, cardiotoxicity, nephrotoxicity, and so many other toxicities. And when we administer cisplatin through the systemic route, we ended up exposing a lot of healthy tissues to very high doses of cisplatin. And on the other hand, it's hard to get higher concentrations of cisplatin inside the tumor. Moreover, recurrence after chemotherapy, surgery, or radiotherapy, it's pretty common in lung cancer, and therapeutic alternatives are very limited for those patients with very low rates of success and a very high incidence of adverse effects. So an alternative to reach higher concentrations of cisplatin inside the tumor, whether reducing the off-target burden of cisplatin, is trying to give cisplatin directly into the tumor with intratumoral injections of cisplatin. And that's where our work here in Vermont sits. I'm going to give a retrospective, some background of what we have done in intratumoral injections of cisplatin for treatment of lung cancer. And our first work was in the end of 2014, early 2015, when the group published this paper describing the technique for the first time. It's called endobronchial ultrasound-guided transbronchial needle injection. So we have kind of a bronchoscope traveling inside the airways, and attached to the probe of this bronchoscope, we also have an ultrasound probe, so we can visualize, we can have transbronchial images of the lung tumors or the lymph nodes, and then we can place the injection for either aspiration or injection. So this technique was used for one patient that had non-small cell lung cancer, a recurrent non-small cell lung cancer following chemotherapy and radiotherapy. It's important to say that the tumor was in a region that was accessible through the bronchoscope. And the idea of using an ultrasound-guided transbronchial needle injection is because aspirating lymph nodes or lung tumors for biopsies, it's a pretty standard practice in the clinic. So, I mean, doing the injection is, instead of aspirating, moving the fluid to the other direction and injection. So it's a technique that was pretty much dominated by thoracic oncologists. And since then, we have been using this as a salvage therapy for patients who doesn't have therapeutic alternatives for treatment of recurrent lung cancer. So here we have some images showing how this technique works. Let me take a laser. We have here the bronchoscope traveling inside the airways. We have a white light on the tip of the bronchoscope. And we also have an ultrasound probe here. That ultrasound, with the ultrasound, we can see beyond the wall of the airways. And it helps placing the needle here. So here we have a lymph node and the aspiration of a lymph node. And here we have the ultrasound image. We can see the borders of the lymph node and the position of the needle. Here we have a video with the simulation of the aspiration of a lymph node. So we have the bronchoscope here, we have the ultrasound probe attached to the bronchoscope, and we have a needle. So it places here, and then it guides the position of the needle inside the lymph node. It can be in the tumor too, if we're doing a biopsy or an intratumoral injection. So here we can see the border of the lymph node, this bright area here. You can see the needle moving here, and this dark area is inside the lymph node. So this is an image, a pre and post treatment of a patient made by the bronchoscope. So on the left, we have a lung cancer, and we can see that it's obstructing the right inferior lobe of a patient that was previously treated with radiotherapy. And after the treatment, we could see an improvement in the patency of the distal airways. And also the patient reported an improvement in dyspnea and chest pain after receiving intratumoral injections of cisplatin. And here we have CT scans of the tumor before and after intratumoral injections of cisplatin. So this is before treatment and this is after treatment. We can see a reduction in the size of the lesion after 1 month following intratumoral injections of cisplatin. So currently, this procedure has been used at the University of Vermont and also University of Florida. And since 2014, we treated a total of 37 patients with this technique. And out of this group, 71% of those patients showed partial or total response with just some mild side effects. So it's a pretty good rate considering that it's patients with recurrent lung cancer. So following contextualizing the problem and a quick background of our research, we can clearly see that there is an intersection between theoretical biology and clinical practice in this project. However, there's also a lot of open questions in this project that can be answered with computational and mathematical models. And that's exactly where I joined the group with the computational and mathematical models. I'm a physicist with a PhD in biomedical engineering, so I definitely doesn't have a lot of experience in biology and medicine, but I can definitely help a little with the modeling part of the project. So among several questions that we aim to answer with modeling in this project and biophysical studies is a discussion around what is the ideal regimen of drug delivery. So is it better to give one single injection in the middle of the tumor, or is it better to distribute the cisplatin in multiple injections throughout the tumor? A second question is around dosing and how much cisplatin should we deliver to the tumor according to the volume of the tumor, according to the shape of the tumor. Is there a way we can optimize dosing, avoiding potential harmful side effects for the patients? And we also want to understand how cisplatin distributes in the tumor immediately after injections. We know that the tumor microenvironment is very heterogeneous. It can be very different from one patient to another. So it would be interesting to see what are the main drivers of the initial distribution of cisplatin inside the tumor. So first, let's talk a bit about the number of injections and how can we optimize the administration of cisplatin. So first thing to do when modeling the number of injections is try to understand what are the main physical mechanisms that drive cisplatin transport inside the tumor. And once we define what are the main drivers of this transport, we need to put this in equations. We need to set the parameters, like fine-tune the parameters, and implement optimization algorithm in order to optimize drug coverage inside the lesion. And following this, we aim to answer whether is it better to give one single injection one time or split the dose in several injections around the tumor. So this was a modeling exercise that we published on Scientific Reports in 2019. So let's first discuss a little about what are the driving mechanisms of transport inside the tumor. So based on the CT scan, the chest CT scan, and the segmentation of the lung tumor, we have a three-dimensional reconstruction. And this was divided in several voxels. It's like several small cubes that composes the lesion. We can divide every single voxel, every single cube, in an extracellular component and an intracellular component. So once cisplatin is injected in the tumor, it goes straight to one of the extracellular voxels from the CT scan. And once cisplatin reaches the extracellular space, it can follow three different ways. It can diffuse to neighbor extracellular spaces through diffusion. It can travel to the intracellular space, or it can sink to a fluid space. So on the intracellular space, we assume that cisplatin exerts its cytotoxic properties, inducing cells to apoptosis once it gets above a certain threshold concentration. So it was just a simplifying assumption, so the model could be handled in an analytical shape. So we assume that cell apoptosis is linked to reaching a certain concentration, although we know that the mechanisms are way more complex than just this. We assume that the fluid space is composed not only by the blood, but also by other interstitial fluids where cisplatin can accumulate in the body. So we have that every single voxel, every single extracellular space cube is connected to the fluid space through small vessels that could either be blood vessels or lymphatic vessels. And once the cisplatin reaches the fluid space, it's filtered by the kidneys and then it's secreted by the body. So this is the general structure of the model. Those are the driving mechanisms that we assume in this model, and those are the compartments that we consider in order to do that computational model. So once we define the mechanisms of transport of cisplatin inside the tumor, we put all of those mechanisms in equations and we fine-tune the parameters. We then adjust the model for the cisplatin levels in the blood. So following injections of cisplatin, we measure cisplatin concentration in the blood of one patient that are represented by those small dots here, those open circles. And we fitted our model to this data. So this full line here is the fitted model. And we can see that the model fitted pretty well to experimental data. So yeah, the model seems to be working. Once we build the model, we put all the mechanism in equations and we calibrated some parameters based on model fit to data. We then use an algorithm with trying to minimize the cost function in order to find what would be the ideal positions of the injections inside the tumor. So we made some simulations for 1 to 6 injections, and we used the model to set what would be the best places to set the needle when the dose is divided in 1 to 6 injections. So it's pretty clear that for one injection, the best place is in the center of the tumor, but that changes once we are given more injections. So this silhouette here is a 3D reconstruction of the tumor in this gray shape here, and the darker dots are the optimal position of the injection. So we believe that this model could be used in clinical practice in order to guide the surgeon on what would be the best places to put the needle in order to achieve an optimal drug distribution inside the tumor, assuming that the governing mechanisms of transport are diffusion and traveling to the intracellular and the fluid space. So the last question we want to answer with this model is it better to give one single injection or split the dose in multiple injections? And the result we've got from the model is very interesting. So in the y-axis, we have the total dose to cover the whole tumor with a certain concentration. And it's worth mentioning that this is in a log scale. It's not a linear scale. And just by splitting the total dose in 5 injections instead of 1 injection, we can reduce the total dose by up to 3 or 4 orders of magnitude. This is a lot. This is a big reduction just by dividing the dose in multiple injections. And this is a straight consequence, the fact that diffusion is a much slower mechanism than drug clearance inside the tumor. So once we give the injection, the tumor takes off the drug very fast in the fluid space. So, and diffusion is very slow because the tumor are usually denser structures, and they have a lot of fibrotic areas too that impairs diffusion. So it's much better to give in multiple injections instead of just 1 injection in the middle. So this is the first question we try to answer using modeling for this project. Let's talk a little about dosing based on the tumor volume. So one of the main issues of the first version of our model is that we consider that the threshold concentration in the intracellular space to induce apoptosis was empirically defined. And furthermore, the first version is much more a proof of concept because it was just validated in 1 patient in the blood levels of cisplatin, the cisplatin levels in the blood of just 1 patient. So how does this model will compare when we apply that to a larger set of patients? And based on these problems, these issues that we faced in the first version of the model, we want to get deeper on a volumetric dosing algorithm for intratumoral injections of cisplatin. So let's first talk about the threshold concentration to generate apoptosis, and also talk about how can we define response to treatment for tumors. So we analyzed data from IC50 in non-small cell lung cancer following after 72 hours of cisplatin delivered in several lines of immortalized cells of lung cancer in a database called Genomics of Drug Sensitivity in Cancer. And we found that it's a very heterogeneous distribution, but it fits well in a log normal distribution. So we use those values to inform what would be the minimal concentration to induce apoptosis in lung cancer cells. To add a first layer of heterogeneity in the model, we define for each voxel, we define the minimal concentration of cisplatin in the tumoral space based on a random value pulled from this log normal distribution. So every single voxel of the tumor will have a different threshold concentration, and this threshold concentration will be pulled from this log normal distribution. And lastly, we use RECIST 1.1 criteria to define what is a therapeutic response. And RECIST 1.1 assumes that a positive response to treatment is represented by a total reduction of at least 30% of tumor diameter. So by assuming that the tumor is roughly spherical, that would be around 67% reduction in tumor volume. Based on that, we compare the results of our model in a set of 32 patients that went through treatment. And we're going to compare how our model predicts response and what are the true responses in this data set of patients. It's worth mentioning that this is a very heterogeneous data set. So the volume of the tumors are very different between the patients. The amount of cisplatin they receive is also very different. The number of injections the tumor receives is also very different. And it's interesting because this is one of the reasons why we think models are so important So we can balance all those differences and give different weights to those differences in the model. So we can set all of them in the same basis for a comparison. Otherwise, it would be just impossible to compare such a heterogeneous data set. So in this group of 32 patients, we were able to predict the therapeutic response in 72% of them with 5 false positives and 4 false negatives. So, I mean, this is a very simplified version of this is a very simple model in general that just accounts for cisplatin cytotoxicity in order to induce therapeutic response. And we know that there are several other factors that might play a role in the response. So, I mean, we didn't expect to see like 100% accuracy in predicting response anyway, but we think that 72% is a reasonable number if we assume all the limitations of the model. And lastly, we made an algorithm in order to estimate what would be the minimal dose to induce a therapeutic response for every tumor in the data set we have based on RECIST 1.1 criteria. So in the left plot, we have in the y-axis the minimal dose to induce a therapeutic response, and the y-axis the tumor volume. It's in a log scale. So you can see that even though it looks linear here, as it's in a log scale, that's a very nonlinear relationship. So we see that once the tumor volume increases, the amount of cisplatin requires to induce a response increases dramatically. So we have in different colors here the different number of injections. So 1, 2, 3, 4, and 5 injections. So we can see a brutal reduction in the total amount of cisplatin to induce response once we give the total dose in 5 injections instead of just a single injections in the middle. And I mean, although it looks super, it doesn't look straightforward at first. It's kind of natural that if we distribute the injections around the tumor, we would have a better response, and that's totally feasible in the surgery. So. And also, we've been doing this in Vermont. We've been doing 4 to 5 injections in our patients, and patients seem to tolerate that very well. So on the right here, we have the regimen for 5 injections, and we can plot a linear regression on dose and tumor volume in a log scale. So this might be a good algorithm to estimate what would be the ideal dose based on the tumor volume for its different patients. So we don't underdose large tumors and we don't overdose small tumors. And nowadays, there are 2 different strategies for dosing intratumoral injections of cisplatin. The first one is given 40 milligrams of cisplatin, regardless of tumor size. It's kind of a largest tolerated dose, maximum tolerated dose regimen. And the second strategy is given 1 milligram of cisplatin for each milliliter of tumor. So we found that both of those strategies might not be optimal. As I said, they are underdosing very large tumors and they are overdosing very small tumors. So let's go for our third question for this project, which is something I've been working in the past few months, which is trying to understand how cisplatin distributes in the tumor immediately following injections. So from the first version of the model, we found that diffusion is a very slow process and drug clearance occurs much faster than diffusion. So the way cisplatin distributes in the tumor immediately following injection, it is very, very important in order to understand drug transport. So Yeah, that's where we are trying to understand. In the first version of the model, we just assume that all the cisplatin sits inside one voxel, but we know that that's not very realistic. So in this first phase of this assessment of initial distribution of cisplatin in the tumor, we first want to make a qualitative assessment of the cisplatin dynamics following injection. Then we are planning to do a quantitative assessment of cisplatin distribution. And following, we want to try to infer what are the dominant physical mechanisms that might be driving that distribution inside the tumor. And to do that investigation, we've been using the ultrasound images generated by the ultrasound probe attached to the bronchoscope. And even though ultrasound doesn't have a very good spatial resolution, those videos have a great temporal resolution. So we can see some very valuable information just by looking at those ultrasound videos. So let's just make the first qualitative assessment, and I'm going to show some videos of the ultrasound probe following the procedures. So here we have the ultrasound cone area. We can see this bright area here. This is the needle. This bright area here around is the border of the tumor. Each tick here is 5 millimeters. And then I'm going to play the video, and I would say just pay attention to the tip of the needle where a cisplatin starts moving. We can see some artifacts due to heartbeats, and then you can see the cisplatin distributing inside the tumor following the injection. Has a brighter area here. Interestingly, in this case, cisplatin moves in the same direction of the needle, and it deposits in the tumor in like symmetrically around the needle tip within the same axis of symmetry of the needle. So we can see that bright area here. And we don't see an expansion of the tumor once we give the injection. So this is a second video. Here we can see the border of the tumor is much clearer than the first video. We have this border here, we have this border here. You can see the shape of the tumor more around here. Here we have the needle, and again, I would say pay attention to the tip of the needle where the drug moves. So once we give the injections, we have a very bright area. We cannot see the border of the tumor anymore. Though you see that immediately following injections, you have a brighter area here in the border of the tumor, which means that drug is probably accumulating in the border of the tumor, in the edges of the tumor, which is something actually very common. The interstitial fluid pressure of tumors are usually very high. So when we do the injections, the drug looks for brittle interfaces and then accumulates in areas of lower interstitial fluid pressures, which are usually the borders. So it's interesting to see how it floods all the tumor, but it quickly moves to this area of lower interstitial fluid pressure. And this is the last video. We can also see the borders of the tumor very clear here in the video. We can also see the needle. And again, I would say pay attention to the tip of the needle where the drug will start moving. And in this video, we also see that cisplatin pretty much floods all the tumor. And we can see some expansion of the tumor here. You can see that this border moves a little once we give the injection. So that's something that we were not expecting to see that much expansion. So that was a very interesting observation we made on this video. So when we look at the ultrasound images, and we also look at the bronchoscope image, the white light bronchoscope image, something that it's very well described in the literature that we don't observe is the backflow of cisplatin through the channel generated by the needle. Once we pull the needle back, the high pressure inside the tumor pushed cisplatin through this channel and floods the airway wall with the airway lumen with cisplatin. But interestingly, that's something we didn't observe. Maybe because we pulled the needle very fast, so the pressure in the tumor really collapsed that area, closing the tumor and sealing it without having some leakage to the airway lumen. We also didn't observe drug extravasation beyond the borders of the tumors and extravasation back into the airway lumen. So a possible mechanism that we saw, especially on video 2, was that drug finds a pathway with brittle interfaces and then accumulate in the edges of the tumor, which is an area of lower interstitial fluid pressure. But anyway, on the set of videos that we watched, we see that the behavior of cisplatin is very heterogeneous, and it's very hard to predict what's going to happen to cisplatin once we give the injections. For the three videos that I showed, every single video had a different pattern. So let's make a deeper quantitative assessment of a data set. So in total, we analyzed 13 videos, although we were just able to see the drug was visible in just 5 of those videos. So we used some image processing algorithm in order to make an estimation of the wet front, the area of cisplatin, in an automatic way. So the first step of the image processing algorithm was removing the background, removing the bright areas of the needle and the borders of the tumor. We also made a moving average of 1 second before the injection in order to remove those artifacts related to heartbeats. You can see that the image moves around every second due to the heartbeat. So we removed the background. Following, we applied a filter to every frame of the video that smooths the video, and also it highlights big steps in intensity changes. So it highlights the borders of the areas corresponding to cisplatin. And then we use an automatic segmentation algorithm in order to define what is cisplatin and what is tissue in the ultrasound images. It's called the O2 algorithm. It's based on the distribution of intensities inside the images. So we can see this is the automatic segmentation of the first video. So we have some selected frames like 0.03 seconds after the injections, 0.07, 0.1 second, 1 second, 5 seconds, 10 seconds. So that's very interesting to see the distribution of cisplatin following injections. And we can see what I told about the cylindric symmetry around the tip of the needle following the needle axis. It's worth mentioning that there is an angle in the tip of the needle. That's why it doesn't follow straightly the needle. It moves around like 15 degrees. So this is for the second video. We see that it quickly floods all the tumor, but around like 1 to 5 seconds, it starts finding a brittle interfaces and a pathway of less resistance. And then after 10 seconds, it's all accumulated in the border of the tumor. So for the 5 videos that we analyzed, based on the area, the estimation of the area of cisplatin in the video, we try to estimate what would be the percentage of drug retention for every single case. What we observed that the amount of cisplatin that remains in the tumor after like 10 to 20 seconds of the injection is below 20%. This was the highest one, around 16 to 18. But for example, for this one, the amount was pretty low. So this is the one that accumulated in the edge. So possibly there was some huge extravasation of cisplatin through the borders. Some part accumulates there, but some parts extravasate. So we see a large retention, and then it dramatically drops to like below 1%. So, I mean, we just saw accumulation in the edge in this video, but for all of the other videos, we didn't see backflow through the channel generated by the needle. We didn't see extravasation through the borders based on the ultrasound images. We didn't see extravasation to the airways based on the bronchoscope. So we speculate that the dominant clearance mechanism of cisplatin following intratumoral injections is that a huge amount of cisplatin quickly finds blood and lymphatic vessels that are quickly cleared out of the tumor in a matter of seconds. And then following this quantitative assessment and some modeling, some biophysical models of the tumor, what we would infer from those videos is what are the dominant mechanism of the dominant physical mechanism following injections? And we raise it two different possibilities. The first one is a Darcy flow, which is also known as flow through porous media. So think about a sponge. It's like water flowing through the pores of a sponge. And the second possible mechanism is that the pressure of fluid in the needle tip is so high that induces a fracture in the tissue and creates kind of a pocket that accumulates drugs inside it. So let's first talk about the first physical mechanism that we speculate that is a Darcy flow. So let's suppose that the dominant mechanism of cisplatin movement following injection is flowed through a porous media. Here we have a video representing what that would be. So we have the pores here, we have the fluid, we have some places with high velocity, places with low velocity, some places of stagnation, but we can use some stochastic models in general to observe this. So let's model this. I'll not get in details about the mathematical development of this model. I'm just gonna say that this variable here is called hydraulic conductivity of the tissue, which is a physical property of a material and is well described in the literature for tumors. This variable here is an estimation of the flow rate of cisplatin inside the tumor. This variable here is the interstitial pressure inside the tumor. And this variable here is the size of the wet spot of cisplatin following the injection. And this variable here can be estimated based on the ultrasound video. This is more or less this variable. So the very interesting thing about assuming a porous, a flow through a porous media is that once we put all the values in the equation, the estimated value for the hydraulic conductivity is 10⁻³ to 10⁻². However, literature values are around 10⁻⁷. So this is a huge difference, like 5 to 4 orders of magnitude. And I mean, it's very unlikely that this is a dominant mechanism in the tumor if we are seeing such a brutal difference in the order of magnitude of this value. So based on the data we have, there doesn't seem to be a Darcian flow inside the tumor following injection. So the second hypothesis is that the pressure in the tip of the needle generates a fracture of the tissue. And that fracture propagates, and as the tissue is elastic, it creates a pocket of drug where it accumulates inside the tumor. So just showing what does it mean. So we have kind of an acrylic plate here, and we have an edge here that is putting pressure in this acrylic plate. So we see a fracture being induced. And once the pressure is increasing, we see that this fracture is propagating around the material as the pressure. And we also see a big pocket here that has been opening. It's been that the edge opens, it raises the pressure inside the material. So we speculate that pretty much the same thing happens in the tumor. It creates a pocket, but the difference is that the tumor is a little more elastic. So this pocket can expand to the sides too, and the cisplatin can accumulate in in this area. Again, I'm not going to go deeper on details of this model, but this is how we estimate whether or not there is some tissue fracture in the tumor. So this is based on the pressure of the fluid in the tip of the needle. This is the Young modulus of the material. It kind of measures how elastic the material is. This variable here is what we call fracture toughness, is how resistant a material is to fracture. And this variable here can be estimated, again, based on the ultrasound video. So it's frozen. Okay. Yeah. So based on this value here, we can estimate whether or not there is tissue fracture. So the minimum value that this part on the left needs to reach in order to get a fracture is 1.128. And based on the set of parameters we have, this value here in our system ranges from 0.76 to 18.97. So even the worst case scenario, it's pretty close to the fracture threshold. So it seems pretty possible that we reach the fracture threshold, and we are seeing some fracture in the tissue in this model. Yeah, so based on this, we consider that tissue fracture and propagation of this fracture within the same axis of the needle is probably the dominant physical mechanism, and is much more likely than a Darcy flow through the media. Actually, I mean, honestly, we don't really know what does it mean in order to optimize drug distribution and optimize injection. That's something that we are still thinking about. What are the implications of this in the way we deliver injections? Because ideally, the slower we give the drug, the better it is. But there is a limitation, that is how long the patient can stay there receiving the injection. I mean, we cannot inject cisplatin in like 3 hours in a patient. The patient just cannot stay there for so long. So we are balancing, I mean, trying to give as slow as possible, but within a range that is reasonable for the therapy. So yeah, this is the end of the presentation. I'd like to thank the Damon Runyon Cancer Research Foundation for the funding, and also my mentors, Matt Kinsey and Jason Bates. And that's it. I'm open for questions.